Okay. So what are the other cardinal symptoms, by the way? I told you, three major cardinal symptoms. What are the other cardinal symptoms? Okay, palpitations, of course. So how will you explain palpitations, or how will you maybe define palpitation? So what do you mean by palpitation? See, dyspnea definition is unpleasant awareness of one's own breath. That is dyspnea. That's unpleasant awareness. That's why after exercise, if you get dyspnea, we don't classify as dyspnea, because it is a normal physiological phenomenon. It's a pleasant experience. It's not an unpleasant experience. So unpleasant awareness of one's own breathing is what we refer to as dyspnea. It's a subjective symptom. So after sexual activity, many people get dyspnea. So do you call it unpleasant? So will you call it dyspnea so that you go to the doctor, sir, after sexual activity, I have increased rate of breathing. So should I be worried? Okay, if the patient is coming, you should be worried, because after sexual activity, if they get some unpleasant awareness of dyspnea, means there might be a cardiac disease. Obviously, yes. So as a doctor, you should take it significant, but the patient himself knows, isn't it? So what is significant and what is not significant? So it's an unpleasant awareness of one's own breath. Similarly, what is palpitation? It's an unpleasant awareness of one's own heartbeat. So sometimes after exercise, you get palpitations, isn't it? After working out, you get palpitations. So that you don't call it as palpitations, by the way, even though it's a very thin line whether you call it or not. But ideally, it's not troublesome, or it's not something that's going to really matter. So unpleasant awareness of one's own heartbeat is what we refer to as palpitations. So whenever you talk about palpitations, how will you differentiate palpitations? What are the types of palpitations we have? What are the types? What are the cause of palpitations, you can say? Okay, first, again, we can pick up cardiac causes. Cardiac cause of palpitations. Of course, you can get in multiple conditions. Arrhythmias is the number one. Of course, whenever they say palpitations, you are going to think about arrhythmias as the first possibility. Arrhythmias means what kind of arrhythmias? You can get in premature contractions, or you can get in some atrial as well as ventricular tachyarrhythmias. Ventricular tachyarrhythmias also. Typically, what is the type of palpitation that you get in premature? Beats. Premature beats, see, per day up to even 1,000 beats, they are saying it's normal. Premature contraction, because heart beats 60 to 100 times every minute, and per day it can beat up to 1 or 2 lakh times. So in that, getting up to 500, 600 premature contractions are absolutely normal. But normally we'll get around 100 to 200, but we still do get premature contractions every day, most of us and all of us, in fact. But if it comes frequently, then that becomes troublesome. Premature contraction. What is the problem with premature contraction if it comes frequently? Because it's premature contraction, the ventricle will not have adequately filled by the time you produce a contraction. So there is a risk of developing fatigability, low cardiac output. So that is possible if it comes frequently again and again, and it can cause palpitations as well. That awareness. So very commonly, premature palpitations will come as a missed beat. Okay, skipping of a beat or a missed beat. So that is how they typically tell, or they can say that it comes faster, earlier than what we predict. Most of the patients will not be very clever like that, but they will often tell it as a missed beat or a skipped beat, because it comes very prematurely and they will not be able to feel the next beat. And premature contractions will be weak. Why? Because by Frank-Starling law, your end diastolic volume will tell the power of contraction. So because it's a premature beat, the filling will be less. The end diastolic volume will be less, the force of contraction will be less. So the patient will not be feeling that beat. So they will not feel that beat at all. So after some time only the next beat will come. So they will feel it as what? Missed beat or a skipped beat. So this is equal to something called extrasystolic palpitations. So in exam, if they typically ask you, what do you mean by extrasystolic palpitations? You have to say, sir, it is because of the premature contraction, especially ventricular premature contraction, that produces a sense of skipped or missed beat, which is typically defined as extrasystolic palpitations. If it's a sustained atrial or ventricular tachyarrhythmia, that is called as what? Tachycardic palpitations. That's called as tachycardic palpitations. If it's a sustained ventricular tachyarrhythmia, atrial or ventricular, they'll produce a sense of sustained tachycardia. It can be regular or irregular. It can be regular palpitation or irregular palpitation. For example, AF you will get irregular. In VTs and all, it can be regular. Other atrial tachycardias, SVTs can produce regular palpitations. So it depends on what is the underlying palpitation. It can be regular or irregular, but it will be sustained. It will not be like a skipped beat. That's called tachycardic palpitation. Then apart from that, we can get palpitations due to some structural heart disease also. Structural heart disease also can produce palpitation. The characteristic example is your MVP and MR. And one of the important early symptoms of mitral regurgitation is palpitation. Why? And MVP also. Why? Because of the MR, there will be more volume in the ventricle. Okay? Because of more volume in the ventricle tries to push harder. I don't know. I wanted to show you some, funny videos in, I don't have it now. Previously, I used to show in 2019 and all. So we have a joke where there will be an actor called Vadivelu will be there. In South India, I think everyone will be known. It's an old joke actually. He tries to, there will be a, the mat will be there. You will try to open the mat. It will close from that side. You will try to open this side. It will close from that side. MR and VSD are something like that. What's happening? The ventricle is ejecting. It's going back to the left atrium and coming back to the left ventricle again. And it's trying to eject more harder. Again, it's going back to the left atrium and coming back to the left ventricle. So ideally, who's getting overloaded? Finally, the left ventricle is getting overloaded. To avoid this overloading, at every beat, what's happening? The Frank-Starling law is applicable. So what Frank-Starling law says, with increased end diastolic volume, your force of contraction will increase. Because of increased incoming blood from the left atrium with every beat, okay, your EDV will be high and force of contraction will be very high, and that will create a sense of palpitation to the patient. So one of the important cause of palpitation is MVP and MR. And even AR also similar mechanism. AR patients also can experience palpitation. So any structural heart disease like valvular heart disease patients can develop palpitation. Even MS can produce palpitation because very commonly they will end up with atrial fibrillation. So anything, like any valvular heart disease by definition can result in development of palpitation, especially MR and AR because of increased inflow to the left ventricle at the end of the diastole. Okay. Apart from that, cardiomyopathies can produce. Whenever I write CMY, it is cardiomyopathy. Okay. So that's how we write generally. CMY is cardiomyopathy. Cardiomyopathies. Then many congenital heart disease. I told you, VSD is also similar mechanism. What happens in VSD? Extra blood is shunted towards the left ventricle only. See, in VSD, what happens? Your left ventricle contracts, right ventricle also contracts. Remember, during the shunting from the left side to right side, your right ventricle is also in what? Systole, which means the right ventricle is not dilating, as contrary to the popular belief that people think that right ventricle is dilating because of blood coming into the left ventricle. People forget that right ventricle is also under contraction at the same time of left ventricle. So the blood is not dilating the right ventricle actually. The blood is actually pushed even with extra force into the pulmonary circulation. So in a VSD, the right ventricle is used only as a conduit for movement into the pulmonary circulation. So the pulmonary circulation comes back to where? Left atrium and back to the left ventricle. That is a left ventricular failure is very common in VSD. Even before right ventricular failure, you will, in some patients, you will experience left ventricular failure. And again, that depends on the shunt quality. The shunt is very big, things will get faster. The shunt is very small, even at very late stage, it will be normal. You can see like even 40, 50, some patients VSD will be thriving well without any surgery. It's a very, very small shunt, but you'll have a significant murmur called as Maltby-Roger. I'll talk about that later on. Do you understand? So congenital heart disease can result in palpitations. And pacemaker, especially when pacemaker goes into some trouble, you can get palpitations. If the pacemaker synchrony is gone, if it's firing abnormally, so especially in that time, you can get palpitations. And apart from that, these are important causes, but some less important causes are there, like high output states, increased cardiac output states, you can get palpitations. What are the conditions where you have high cardiac output? Where it can cause high cardiac output failure, anemia, beriberi, thyrotoxicosis. There are many conditions are there. See, whenever I talk about high cardiac output state or hyperdynamic circulation, few things you can say pretty easily. Anemia, fever, sepsis, thyrotoxicosis, pregnancy, some children, beriberi, then thyrotoxicosis, thyroid storm, thyrotoxicosis. So these are some of the important causes of hyperdynamic circulation. In any hyperdynamic circulation, they can cause high output state and you can develop high output cardiac failure. And that can result in cardiac palpitations. And many anemic patients, as you can see, they can tell what I have palpitations because of increased contraction of the heart. It will feel like a pounding sensation. And psychomotor conditions. can produce palpitations. You know, psychomotor conditions. It's more of anxiety related. Isn't it? Panic attack, anxiety. Okay, major depression. See, many depressed patients will say, I'm feeling, very down and very fearful, and they will cry and they say, I'm having palpitations. You see, many postmenopausal women will say that, I'm feeling palpitations. That is kind of fear. Because of that, they get palpitation, amygdala activation. Okay, psychomotor complications. And many miscellaneous and idiopathic conditions are there. Like, if you want to say, you can say vigorous physical activity. If you want to put that under unpleasant, I mean, again, there's a thin line of differentiation. I cannot really say whether it's palpitation or not, but if you want to include, you can include physical activity, some kind of emotional stress. The patient is hyperventilating. In these situations and all, you can get slight palpitations, which is possible. These are last and least. It's not at all important. The patient is coming and telling palpitations, you need to think about something very important. And that is why these two are very, very important, because these two will tell you that it's very likely to be an arrhythmogenic cause of palpitation. That is why we need to take these very, very cautiously. Whenever they say sustained regular or irregular palpitations, it doesn't matter whether they are sleeping or whether they're awake or whether they're exercising. At any stage, they will have a sustained palpitation. Okay, that is very specific. Okay, similarly, if they go for exertional syncope or palpitation, they say exertional syncope and palpitation. That's very likely due to arrhythmogenic cause. It's actually cardiac only. You have to be having very high index of suspicion for cardiac cause. If they say it is exertional, very, very important point. Cardiologists will never ignore certain things. One is chest pain. Second is this exertional symptoms. Whenever you become a cardiologist, or if we're not a cardiologist, also doesn't matter. You never ignore patient symptoms. Whatever may be the chest pain, I told you 15 to 25% chance of having ACS. So you can never take it for granted. Always you have to work up and evaluate. If the patient is coming to you with the chest pain, means, see, functionality can be there, functional symptoms can be there, but you cannot miss out on ACS. That is a gross mistake. You will be behind bars. So you can't do that. So always consider any chest pain emergency as acute coronary syndrome unless proved otherwise. That's why you have to be very, very careful. Similarly, any exertional symptoms, never ignore. Exertional syncope, exertional palpitation. Always think about arrhythmogenic cardiac cause. Do you understand or not? But post-exertional syncope is not very much related to cardiac condition. There is an entity called post-exertional syncope. After completing the exertion, when they come and sit, they'll get syncope. Or after finishing, when they start taking rest, that time they'll get syncope. That is more of a subtype of vasovagal syncope only. Okay, that is not related to cardiac cause. So post-exertional, unlikely to be cardiac, but exertional, very likely to be cardiac. That's why that's post-exertional versus exertional is very, very important. Okay, these are about palpitations. Okay, palpitations are not that important. What are the ways while patient will explain the palpitation from the patient words? Patient can say flip-flopping in the chest. Okay, generally flip-flopping will be with SVTs and premature contractions, arrhythmogenic cause. So second, it will be fluttering, rapid fluttering kind of palpitations. This is again a very common notion for your cardiac cause, arrhythmogenic cause, SVT, VT, anything can cause rapid fluttering kind of a palpitation. Tuck, 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 tuck. Like you get that kind of feeling in the chest. So third one is pounding kind of palpitation. So whenever they say pounding in the chest, you have to ask again whether it's in the chest or whether it's in the neck. So pounding in the neck will often go towards a Cannon waves in atrioventricular dissociation or supraventricular tachycardia. If they say pounding in the chest, then that goes towards some other palpitation. Okay, so pounding whether in the chest or in the neck. In the neck means it may relate to Cannon waves in atrioventricular dissociation. So you have to ask in the neck or in the chest. Neck is Cannon waves. Chest probably could be due to arrhythmias. Pounding sensation. So these are the patient words. So in exam, you should use these words only. That's why I told you that. In exams, you cannot say extrasystolic palpitation. Patient is complaining of extrasystolic palpitation. Patient is complaining of, tachycardic palpitations. You cannot say like that and all. You should say patient is telling flip-flopping sensation in the chest. Patient is telling fluttering sensation in the chest. Patient is telling pounding sensation in the chest. So this is how you describe a palpitation in the exam, which is very, very important. Okay, that's why I told you those three words characteristically. Okay. So I think we have covered on the different aspects of palpitations also, which is done and dusted. So palpitation is done. So what else you have in store? Okay, so repeat the history again from the beginning. Let us see whether it makes sense. Shortness of breath for 2 months. Okay, now let us write the history again. Shortness of breath for 2 months. Okay. EC fatigability for same duration for 2 months. Okay. So this is the major symptoms. Okay. So I would, if I were you, I will not say EC fatigability as a major complaint. Patient, if really they say EC fatigability as a major symptom, then you can write it. But generally, when there is a significant shortness of breath, in the presence of a major cardinal symptom, it's very unlikely patient will tell spontaneously a minor cardinal symptom. It's very unlikely. As an examiner, I can understand that. So why? Because if there is a shortness of breath, they will actually concentrate on that only. Only when we ask if you have any other symptom, then only they will say they have EC fatigability. But the primary cardinal symptom, major, is shortness of breath, as we understood. So as far as I know, my advice will be in exam, try to explain shortness of breath and stick on to shortness of breath as much as possible. Okay. So don't say fatigability unless until it is very, very significant, or syncope or pedal edema as a very important symptom in the your major symptom itself. Clear not? Stay them one of the major symptoms: chest pain, your dyspnea, or probably palpitation. So this is what I would consider as a examiner as a major symptom. So if I were you, I will stick on to shortness of breath for 2 months as a major symptom. Maybe in the associated symptoms, I will say what? Maybe I can say minor symptoms, associated minor symptoms also. Okay, so now you said like shortness of breath. So similarly, in the major symptoms, what you are telling in the presenting illness, you should say the symptoms which brought the patient to the hospital. That's very, very important. You should not say like things that are unnecessary. So what symptom brought the patient to the hospital? That's the major symptom. That should be the first, and that's what the priority is. Okay, fine. So shortness of breath is what has brought the patient to the hospital. So tell me the history of presenting illness.
He was reasonably well 2 months back. Then he developed shortness of breath more on exertion.
See, history of presenting illness is according to the statement of the patient only. Generally, that is not required, isn't it? I mean, that's why when you try to be very smart and tell something extra, no, that is where the problem is in exam. Don't say, see, presenting illness is what? You're telling the words of the patient according to the statement of the patient only. If you are confused about whether the informant is the attender, you have to tell in the beginning itself. So even before starting the history itself, you should say that the informant is attender and the reliability is good or poor, based on who is the attender. If it's a mother, father, or blood relationship, reliability will be reasonably good. But if it's a third person, maid, or someone who's bringing the patient to the hospital, then reliability is going to be not that good. So you have to say whether reliability is good or poor, that's all. And say the informant, who is the informant, is the patient himself or is the attender. So at the beginning itself, when you are starting the presenting illness, when you're starting the history itself, you should start with the name, age, and their gender, and the informant who's the patient himself, or is there any attender who's informed, and the reliability is good or not. Only when the informant is not the patient, then you have to say the reliability. And I've seen many people saying the informant is the patient and they will say reliability is good. So if the informant is the patient, then the reliability is obviously going to be good only. So why the patient should lie unnecessarily? Okay, so never use those kind of words. So according to what is the patient's name? Mr. That's very important. Okay. So language, again, when you're presenting, is extremely important. In exam tension, you will forget all these very basic things. So even when you go to a private setup or when you're seeing the patient, always call them Mr., Sir, Ma'am. Even if they are younger to you, always have that courtesy. It doesn't matter if there is younger Mama, Poma. No, you should not do that. Always be very professionally ethical. Be Madam, Sir, even if they are younger. Okay, be very courteous. That's very, very important. Okay, very small girl means fine. You can ask, but still you're going to ask the history from the mother only. So you can still be Madam and Sir. It's very, very important. So he's a Mr. Ruben. Age?
40 years.
Old?
40 years old.
No, again, use the word either gentleman or lady. That's again very important. Okay, this kind of language. When you start itself, the examiner will feel refreshed. Okay, when you see Mr. Ruben, 41-year-old gentleman. So how it sounds? Ruben, 14-year-old male. How it sounds? Are you able to get it or not? Mr. Ruben, 14-year-old gentleman. Ruben, 14-year-old male. So this sounds, I mean, you can see which sounds better. So see, our community is all about your social relationships. That is all about. As a doctor, even more important. I mean, able to converse freely and able to converse in a very ethical manner. The social relationships are very important being a doctor. So communication skills will come over time, but maybe this should not be taught, but anyway, fine. 14-year-old gentleman came with for 2 months. Okay, that's all. Shortness of breath for 2 months. That's your major complaint. So explain your present illness. Reasonably well 2 months back. Okay, fine. Develop shortness of breath. More on exertion, gradually increasing. So what you can say simply, right, in one word. Insidious, that's all. As simple as that. You can, what do you mean by the term insidious? Huh? Gradual. Actually, to be honest, the exact, definition of insidious, if you ask, initially the patient will be very casual about the symptom. He will actually ignore it, but as it worsens and progresses, he will become more aware of something wrong is happening. So this is the exact meaning of insidious in medical terms. So that's what she's exactly telling. Initially, he was okay, he was coping up with the breathless, he's thinking that something okay, he is able to cope up, but slowly it became worse, so that he came to the hospital. So simply you can finish it as, it is insidious and it is progressive, it is worsening. As simple as that. It's done and dusted, that's all. Or if it is sudden, you tell it sudden. Acute onset, sudden onset breathlessness, and it is progressive or non-progressive, you can say. Sudden means mostly you will not comment on progression and non-progression, and if it's coming suddenly means itself it's something major. That's why it's coming all of a sudden. So this is the patient's history according to you. Then so why you wanted to unnecessarily comment on this while walking? You can say initially what NIHA classification, because NIHA is patient's own words only. It's a functional grading only, right? So you can use NIHA itself, because what is the end diagnosis, final diagnosis? Simply I'm asking, what is your final diagnosis? What's this case? It's a rheumatic heart disease, which means you are trying to say that the patient is in failure, right? So it's a heart failure case. So you can use NIHA logically, isn't it? So at the end only I will catch you. So if the patient is not a heart failure case, then they will ask you why you use NIHA. But majority of the case that you're going to deal in exam is going to be valvular heart disease, which is ultimately going to result in heart failure. So that is the reason for shortness of breath. So you can well use NIHA classification here, not a problem. So what is the NIHA grade? You can say initially NIHA grade is NIHA grade 2. Okay, you are saying it's NIHA grade 2 now, grade 4. Okay, it has progressed to NIHA grade 4. Okay. So probably there are multiple reasons why. If I am the examiner, I'll ask you why you should progress to NIHA grade 4 all of a sudden. There are multiple reasons. Okay. NIHA grade 4 means I told you in common practice, it's synonymous with acute decompensated heart failure. In acute situations, it's usually synonymous with ADHF. Patient is decompensating. In 2 months, what is the need for sudden decompensation? In a valvular heart disease, what is the reason for decompensation? Usual reason for decompensation in already known cardiac patient is number 1 cause. In any cardiac disease, sudden decompensation is always an ischemic event, regardless of the underlying cause. Always you have to suspect ischemic event. That is the number 1 cause. Any acute ischemic event would have made the patient decompensated. Apart from that, they could have developed any arrhythmias. Or any other precipitating events like surgery or fever, infection, sepsis, which you could have gone for tachycardia, and because of that they have gone for decompensation. So whenever you say this kind of grade 2 to 4 and all, you have to be little careful, because 4 means you are trying to tell a acute decompensation. So all of a sudden in your history, how long NIHA class 4 was there? 1 week. Again, that is something to be avoided, because 1 week dyspneic at rest, nobody is going to be there in the hospital. I mean, nobody is going to be there in the home. Logically speaking, who's going to be there in the home for 1 week being dyspneic at rest? Not able to do anything. So I'll be asking next question, what was the patient doing for the last 1 week? So you cannot tell that the patient is illiterate. Never comment on those things. Okay, in exam. No examiner likes telling that patient is illiterate, he doesn't know anything. Never comment, don't lose talk. These are a kind of loose talks you do, never do that. So ideally, if I'm on the safer side, what I would have said is, I'd have said patient had an IHA class 2, which has progressed to class 3. That's how the patient had class 3 for the last 1 week. He found something is wrong, so he came. Ideally, your history should be like that. Or if it's class 4, I'd have said, which worsened to class 4 yesterday, so he came immediately to the hospital. That's how you need to address. So that is why, see, somebody has to teach you. So it's not logical to be with class 4 for 1 week. So ideally, I would have said like class 2 to 3 for 1 week, but it was not getting relieved at all. So he came to the hospital. And he's feeling that it is progressing more and more. That's why he came. If it's class 4, history will be all of a sudden last night his breathlessness worsened. He went into practically ADHF. That's why he came to the hospital, rushed to the hospital, emergency immediately. Clear? Don't tell 1 week of NIHA 4 and all, which is very bad. Okay. So class 2 to 4 according to history. Then what happens? Next. Faster. What happens next? No, you need to say like breathlessness itself, you didn't say whether is there any postural variation. So there is no orthopnea. Okay. There is no PND also. There is no PND, there is no orthopnea. Okay. It's very unlikely, because why I'm saying is PND has a very high negative predictive value. What do you mean by negative predictive value? If the symptom is not there, it rules out the disease. PND, orthopnea doesn't have negative predictive value, but paroxysmal nocturnal dyspnea is something that has a very high negative predictive value. Which means if it is not there, it's very unlikely to be a, like heart failure. Technically speaking, these are the numbers that is given in the textbooks. So that's why, so at least your PND should be there most of the times. If you ask the history properly, you are telling NIHA class 4 and the patient is not having orthopnea is unbelievable. Again, it's an ADHF, patient is dyspneic at rest, and you're saying like there's no orthopnea, patient is able to sleep comfortably. Like, doesn't make any logic. Doesn't make. So be very clear. So which means your idea is NIHA, not NIHA class 4, it's actually class 3. You have mistook as class 4 maybe. That's all. Okay, then what else? Okay, according to history, no orthopnea, no PND. So ideally, what I will do is I will change this to 3 in your history. Probably that might be the only mistake you have done. Okay, then no. Easy fatigability. Okay, these are associated symptoms. So first finish off the major symptoms. What are the other major cardinal symptoms you have? So you didn't finish the major itself. Suddenly you jump to minor. So what's the major? So no chest pain, okay. No palpitations. Okay. Again, very unusual. Don't say like the final history has atrial fibrillation in that. You have? Yeah, she has atrial fibrillation. And she's telling no palpitations. Extremely unlikely again. Possible, but you have to substantiate very clearly. If the patient says something, different to the examiner than you are done and dusted. If they say, I have palpitations, so be very clear, are you feeling any flip-flopping sensation in the chest? I don't know how to say in Telugu. We say in Tamil, pada pada. I don't know. What do you say in Telugu? Huh? Tada tada. Okay. No, I did my DNB. Actually, after MD, there is post-MD DNB, right? I did my DNB in Osmania Medical College only. My exam was in Osmania. Long back. So I did in OMC only. My DNB exam, practical exam was in OMC. I saw many teachers I saw there. I got some good friends also there. Some PGs also was there during that time. Okay, it's long back. Okay, so that's why that time they said this, I think, tada 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 something. Okay, that was there actually, to be honest. Yeah. So palpitations. Then, okay, major over, no palpitations. Then, what is minor? No, easy fatigability you told. Okay, the patient is having fatigability. Okay, so that's a tick. How long? For the same duration. 2 months. Okay, whenever there is fatigability, what it indicates? It indicates many things, but in cardiology, what it indicates? Only one thing, low cardiac output state, that's all. Anything that's causing low cardiac output can have fatigability. Apart from anemia, so many other problems are there. So if you want to argue, I can even say a functional problem called chronic fatigue syndrome. But technically speaking, cardiology means low cardiac output is the one that's going to cause fatigability. It's a very important sign of low cardiac output. Okay, then. What are other minor cardinal symptoms? Now, cough is not a cardinal symptom of cardiac problem. What is the cardinal symptom again? Okay, no pedal edema, no swelling of legs elsewhere. Okay, then. I told you syncope, isn't it? Very important. Is there any history of syncope? No. So usually in a cardiac case, your order should be like this only. Order should be in this manner only. Okay, you should never change the order. Major first, minor next. Then you can move on to the other things. So what are the other things you want to say? No. Then go system wise. Generally, generalized symptoms you can keep at the last. Or if it's anything significant, you can say generalized symptoms. Otherwise, if there is nothing significant, then keep the generalized symptoms at the last. Go system wise. What are the other systems that you want to see, especially? Respiratory, CNS, abdomen. These are more important. Then the most often forgotten system is musculoskeletal system. So what is the respiratory system complaint? Cough and hemoptysis, which is very relevant in cardiology case also. Cough, hemoptysis. Okay, many valvular heart disease can cause cough and hemoptysis also. And even certain valvular diseases like MS, because of left atrial enlargement, can result in hoarseness of voice also. Isn't it? So these symptoms are very, very important. So if your case is an MS case, at the end, always try to do the hoarseness of voice also. Try to comment on that if possible. So the patient is not having cough and hemoptysis. Okay. Then again, that's why that NIHA class 4 makes a huge difference, because you're telling patients having severe dyspnea, you're telling pulmonary edema, heart failure is there. In which world pulmonary edema will not come with cough? I mean, without cough. It's very unlikely. Okay, then. I mean, it can be, but extremely unlikely. Okay, then. Other system. No, food and all I don't want. So I want what? Most importantly, diarrhea and abdominal distension. This is what I want. Because ascites, man, very important problem of cardiology, right? You get ascites and pedal edema in many conditions. Huge ascites you can get in patients with constrictive pericarditis also. That's called ascites precox. Even before getting pedal edema, patients with constrictive pericarditis will get severe ascites. That's called ascites precox. Isn't it? So very important symptom. That's why these are all very important, ascites. Then, why diarrhea I'm asking? Why diarrhea? Because many of the cardiac failure patients will have intestinal congestion. And because of intestinal congestion, they can have malabsorption. Okay, so diarrhea history is also very important. And many cardiac drugs that we use also can cause diarrhea. Okay, pharmacological side effects. So diarrhea is also very important thing. Very, very few things you need to ask. Okay, then what else? Nausea, vomiting, if possible, you ask, especially the patients on digoxin, because one of the first sign of digoxin toxicity is nausea and vomiting. I mean, even though you write this as a first side effect for any drug in your pharmacology exam, but in digoxin, it becomes very important. One of the first signs that you encounter in a patient digoxin toxicity is nausea and vomiting. Okay, then what else? Your abdomen, to some extent you have covered, okay? Sometimes patient has scrotal swelling also. You would have seen, isn't it? Ascites patients will have significant scrotal bulge. Even you can comment on that also, the patient tells that in ascites symptoms. Then go for the neurological system. What symptoms you have in neurology? My God. Not somnolence really, but in a patient with this kind of picture, I would more often go for altered mental status, because according to her, it is NIHA class 4. In a NIHA class 4, it's very likely there will be very low cardiac output, pulmonary edema. And because of low PO2, hypoxia, they can go for what? Altered sensorium. And altered mental state is very, very common. Not in cardiology case, in any patients with hypoxemia and hypoxia. Isn't it? So that's why I have to comment on that, altered mental status. So what is altered mental status? Delirium is altered mental status is called as brain attack. Like how we call heart attack. Like that you have brain attack. Any acute altered mental status, we take it as an acute brain injury. Okay, that is delirium. You can get that. Then focal weakness. Very important because patients can develop atrial fibrillation and that could have embolized. So focal weakness is a very important neurological symptom that is associated with the cardiology case. And what are the conditions that apart from AF, you can get focal weakness in infective endocarditis also. And next is headache because patients may be on anticoagulation and they can cause severe hemorrhage. And then that will present as headache and altered mental status only with focal weakness. So many things you can say. So at least these three you need to comment on. No altered mental status, no weakness or no severe headache in the patient. Okay, then hematological system. How will you comment on hematological system? Intestinal congestion because of heart failure. Okay, heart failure can cause protein losing enteropathy also because of intestinal congestion. Okay, then what else you have? Hematological system, bleeding diathesis. Is there any bleeding diathesis? Very, very important. Because if the patient is in AF, if the patient is already having history of bleeding diathesis, that increases the Hasbled score and increases the risk of bleeding. Apart from that, patient can have hematemesis or melena as a sign of problem due to anticoagulation. Patient may be receiving already warfarin or some non-oral anticoagulation, and that can result in development of hematemesis, melena, hemoptysis. Hemoptysis, since we commented already, I'm commenting bleeding diathesis here, or any spontaneous bleeding elsewhere. You can comment on all these things. Okay, so hematological system is something you forget often. Then finally you go to what? Musculoskeletal system. Never forget that arthritis is very important. It could be an acute event of rheumatic fever resulting in acute heart failure due to rheumatic fever. Rheumatic fever can cause acute heart failure because of carditis. So always make sure that you comment on arthritis. And many connective tissue disorders can result in both valvular problems as well as cardiomyopathies. For example, most CTDs can cause restrictive cardiomyopathies, and most CTDs can result in mitral regurgitation as a very important valvular heart disease. So all these things are extremely likely. So never ever forget on arthritis. Do you understand? So please always comment on arthritis. Okay, very important sign. At least minimum you need to comment. Then go for general symptoms. What are the most important general symptoms that you want to cover up? Fever. Isn't it? Fever is a very, very important general symptom. Fatigue can be a general symptom, but since we have covered in the minor cardinal symptoms, so you can comment on fever. Fever is extremely important cardiac symptom. Okay, because you are again thinking about infective endocarditis associated, recurrent URTAs and fever associated with it can be a sign of congenital heart disease. We have studied already. And even acute rheumatic fever, one of the cardinal symptoms is fever. So there are a lot of reasons why we ask fever. Okay, our patient would have developed some other infection, as I told you, that could have precipitated the current heart failure. Patient was stable because of fever, tachycardia, patient have got what? Some other issue completely not related to heart. It could be an urinary tract infection because of diabetes, underlying diabetes, and that could have caused tachycardia and patient would have got your acute decompensation right now. So a lot of reasons are there why you can ask for fever. So fever, never ever forget that. So least minimum, see, remember other things whether you ask, I don't know what is the proforma that is given in Andhra Pradesh, because proforma varies from state to state, hospital to hospital, university to university. So it depends on who's the examiner. So I'm not going to comment on the general proforma that you're going to follow, but at least least minimum, this should be there in any cardiac case or any history taking in the cardiology. Okay. Then you can write PMH. What is PMH? Past medical history. Okay. So that is PMH. So PMH is something that you need to comment on. So is there any patient is having any significant past medical history? Patient had similar episodes in the past. See, thing is now whether you say lightly or close to the mic or away from the mic, everyone is going to hear only. Okay. So you can say loudly itself. I'm not going to tell anything now. Okay. So no similar episodes in the past. Why similar episodes in the past are very important? I mean, it tells you it's a one-off issue or it's a recurrent issue. So that's why we want to ask the similar episodes in the past. Okay, fine. Then apart from that, when you talk about past medical history, even more than that, other things are important. What are other things that are important? What other things are important in PMH? Your comorbidities, comorbid status. That's what I want. Okay, comorbid status. I can simply say comorbids. What are the comorbids? Diabetes, hypertension, Because I told you, these are very, very important cardiovascular risk factors. I mean, can I tell you one interesting thing about diabetes? So many people are undergraduates, so you may not be knowing this. So I will say, whenever you reduce the glucose, there is reduced CV risk. You can reduce the CV risk. True statement or false statement in a diabetic patient. When you reduce the diabetes, when you control the sugars, your cardiovascular risk will reduce. True or false? True statement or false statement? Absolutely false statement. Okay. In a diabetic patient, that's why it might look very controversial, but this is the case. You can go and see any trial. Not even a single diabetic trial till now have proven benefit for cardiovascular risk just by controlling the sugar. Not even a single trial till date have proven just by reducing glucose, you will reduce the CV risk. In fact, even after reducing the blood glucose, your CV risk persists. And almost 18% of all diabetics develop some sort of cardiovascular problem in their life. Very abysmal number. 18% of all diabetics, they cardiovascular disease, number. 18% develop some sort of cardiovascular disease. And that is the reason currently you go and see the guidelines. Current ADA 2021 guidelines, what they have given, you go and see. They would have given, depending on the cardiovascular risk, you can change the drugs. That is why FDA after 2008 have mandated something called cardiovascular outcome trials for all drugs released post 2008. That is because of multiple reasons. For example, drugs like rosiglitazone have increased cardiovascular risk and cause more mortality. And similarly, drugs like first generation sulfonylureas, you would have studied in pharmacology books. They abolish something called ischemic preconditioning. Have you heard of that? First generation, tolbutamide and chlorpropamide. Because of abolishing ischemic preconditioning, they have shown to increase the cardiovascular risk, more cardiovascular issues like coronary artery disease, MI, sudden death and all. That's why first generation sulfonylureas we don't use anymore. Rosiglitazone was banned from the market. It's no longer used. So that's why FDA become very aware of this existing cardiovascular risk of the drugs that's been utilized in the market. Plus at the same time, just by reducing sugars, there is absolutely no evidence they are going to reduce the cardiovascular risk. That is why after 2008, FDA mandated that every drug that comes new after 2008 should get an approval based on cardiovascular outcome trials. So what they said is the drug need not be beneficial for heart. At least it should not be harmful. So in that category, many drugs have got cardiovascular benefit. They have proved that. What are the drugs? You think insulin has cardiovascular benefit? Yes or no? Answer is no. Insulin is cardiovascular neutral. Only 2 insulins have been proven to be cardiovascular safe and neutral. Glargine and degludec. 2 trials, Origin and Devote. No other insulin have been proven to be cardiovascular safe because no trials have been conducted. That's why. That's why if you take the ADA guidelines and see first line insulin, Glargine or degludec. Reason because they are proven to be cardiovascular safe. That's why. And they say like first line injectable drug what you follow is not insulin. It is GLP-1 analogs because they are found to be beneficial in cardiovascular disease. Because now 2 group of drugs, SGLT inhibitors and GLP-1 analogs, have been proven to be beneficial in cardiovascular disease. That is why patient, ADA 2021 says, if you have a patient with a cardiovascular risk, start SGLT inhibitors or GLP-1 analogs as a first line drug to reduce the cardiovascular risk. Because other drugs like metformin, acarbose, DPP4 inhibitors, sulfonylureas, insulin have not proven to be beneficial for the heart. They are neutral, not harmful, but they're not beneficial. Now you can understand why the guidelines are being changed every year, because our knowledge about things improve with each subsequent year. And that is why I'm saying that the past medical history is very, very important. The comorbid status is very important. Diabetes mellitus. Diabetes is a cardiovascular disease. Always understand that. And just by reducing glucose, you cannot reduce the risk. That is why you are giving some drugs that are beneficial for the heart. Do you understand that? Yes. Then what else? You have hypertension, of course. And one more interesting thing that I proved is just by controlling diabetes, you cannot reduce the CV risk, I told you. But the same trials have shown that if you additionally control hypertension and dyslipidemia, your cardiovascular risk reduces. Okay? So that's why controlling hypertension and dyslipidemia is also very important. Statins, very, very important. And they are beneficial for the heart. Very few drugs. And apart from that, what other history you are going to ask? In the past medical history. Okay, any pulmonary disease history you need to ask, definitely. Any primary pulmonary problem is there? Okay, pulmonary disease. Or you can say simply no history of background pulmonary disease. Or you can say no history of COPD, asthma. I generally don't bother if you say anything, because background pulmonary disease is fine. So primary lung issue is not there. As per the patient's words, there is no primary lung disease in the patient. And apart from that, patient is not having primary GI issue, GI disease like IBD, which can increase the cardiovascular risk. Okay, patient is not having primary rheumatic disease in the past, because rheumatic disease, what is the most common cause of death in SLE? Cardiovascular risk. What is the most common cause of death in rheumatoid arthritis? Cardiovascular risk. Have you heard of that? That's why asking rheumatic disease history is very, very important. Okay, not just because an undergraduate, your mind will be going only to rheumatic fever. Okay, it's not that. Any rheumatic disease can cause death. Only one exception is scleroderma, where the patients will generally die because of primary pulmonary problem, not cardiovascular risk. But SLE, RA, Sjogren, the most common primary reason for death is heightened cardiovascular risk. Okay, MI, that's the usual reason for death. And you have to comment on renal disease. No primary renal disease in the past. So why renal disease is very important? What is the most common cause of death in CKD patients? Cardiovascular risk. In any CKD patient, irrespective of the stage and irrespective of the underlying cause of CKD, cardiovascular risk is the #1 cause of death. Okay, if you see any nephrologist, a CKD patient having a sudden dyspnea and pulmonary edema, first thing they will do is see the MI, whether MI is there or not. So cardiovascular decompensation, CV risk is the #1 killer as far as CKD is concerned, irrespective of the cause and irrespective of the stage of CKD and irrespective of whether the patient is on dialysis or not on dialysis. Yes or no? So that's why these are extremely important with special regards to cardiovascular issue. Okay, all these things should be asked. It doesn't mean only diabetes, hypertension, and dyslipidemia. So whenever I say pulmonary disease means, why I'm saying this is because that includes pulmonary tuberculosis, so many things. That's why be precise and crisp in your presentation. Otherwise, you will miss PTB. You will say COPD and bronchitis. Patient will ask, what about PTB? So just finish off, no any primary pulmonary disease, no history of primary gastrointestinal disease, no history of any primary respiratory, your neurological disease or respiratory disease, or your rheumatological issue or renal issue. So you can just finish off with that. Past medical history. Okay, then some people will expect, like variation of past medical history is the genetic history. Okay, that's a variation. If you want to ask genetic history, you can ask genetic, is the disorder there in their family or not? So this is important, especially when you are suspecting a syndrome. Apart from that, the genetic history is not that important. Okay, genetic, or we can call family history. In one area where family history may be important is maybe in rheumatic fever, where multiple people in the family may be affected in rheumatic heart disease. So apart from that, nothing significant much. I won't be very particular about this as an examiner unless and until it's an oldie. Then marital history is very important. Okay, especially whether it's a consanguineous wedding or a non-consanguineous wedding. That's what I want, because certain congenital heart disease run through families. So that's why I want that. So which has more risk, autosomal dominant disorders or autosomal recessive disorders? Which are at more risk for consanguineous marriage? Autosomal recessive problems. Recessive problems are having higher risk to run in families with consanguineous weddings, not dominant. Dominant generally will come irrespective of whether it's a consanguineous wedding or not. Okay, because it's a dominant gene. Okay. Recessive needs another pair, isn't it? Then only you can get the disease. Only with one gene you will be a carrier. You won't harbor the disease. That's why marital history is very important. And probably extramarital affairs, that's a sensitive area, to be honest. In some areas that may be important, particularly if your case is an AR case, maybe syphilitic AR, they might ask that, but extremely rare nowadays to go into the syphilitic AR category. Many patients will get treated in the primary or secondary syphilis stage itself. Okay, so it doesn't go up to the level of tertiary syphilis and getting a AR and all. So extremely unlikely, but that's again, it depends on your local college formulas, what they prefer and what they don't prefer, what your internals say. If you're a DNB, I would say like DNB is more tougher than challenging than MD exams. The reason is because in DNB you write somewhere. You don't get the support of your parent college. In an MD exam, you get the support of your parent college, isn't it? There will be whole world to help you. Still people fail. So there will be internals who will be there to help you. There will be your juniors will be there to help you. There will be interns who will be there to help you. Still people fail. That's sad state. But DNB is more challenging, to be honest. I don't know why people feel DNB any less compared to MD. I did both, but I'm telling from a common point of view. People still feel DNB is inferior to MD. I have absolutely no idea. Like MD is a national exam. DNB and DNB is accredited in many other countries also, to be honest. Some small countries like Singapore, Malaysia, and all, they have accredited DNB. MD is not accredited anywhere, even in Bangladesh and Sri Lanka also. Outside India, it's invalid. DNB is valid in certain countries, and DNB is a national level exam. And DNB is something you pass without help of anyone at all. But still, people feel like DNB is inferior. Irony of life. And I would say it all depends on how you take psychologically. I would say like there's no harm. I'm never ill-treat anyone. That's what it is. At DNB, no, don't do that. In a way, they are better, I would say. Okay. So marital history. Then what else? What else you will ask? Other things, it depends. Diet history, it's your call. It's a variation of past medical history only. It's your call again. So whether you want to ask or don't want to ask, depends. I don't give a bloody damn about diet history or not. So whether take non-vegetarian or vegetarian, who cares? Maybe in a neurological issue, maybe vegetarian have B12 deficiency, so I can think about something. But the problem is oldies will persist on this. They will ask, what if the patient is having nutritional deficiency, B1 deficiency, beriberi causing heart failure? These kind of arguments I cannot help. Okay, then selenium deficiency can result in cardiomyopathy. Keshan's disease, isn't it? Zinc deficiency can result in acrodermatitis enteropathica. Yes or no? So if you argue, you can argue. But my question is, how will you find out zinc deficiency by history? How will you find out selenium deficiency in history? How will you find out, like what deficiencies the patient is having just on history? Okay, the patient is having some other associated symptoms, then you can say suggest some deficiency. For example, angular cheilitis, think about a iron deficiency very commonly. Glossitis, think about a B12 deficiency very commonly. Dermatitis, think about a B5 pellagra or probably a zinc deficiency. Heart failure, think about a selenium deficiency or B1 beriberi thiamine deficiency. So if you have some associated feature, I can say probably what is the deficiency. But just by asking the diet, in which world, like you're going to find out, I don't really understand. But very commonly, the oldies generally tend to argue to the students, what if the patient is having this, that? I don't understand the logic, but I've seen very, like pity for the students who are sitting in front of those oldies, getting bashed by these kind of nonsensical questions. But argument goes that way. And one more important golden rule in exam is never argue with the examiners at any cost. Never ever argue. That too, especially with the Indian examiners. In US and all, you can easily argue, nobody will bother. In India, never argue, because in India, the people's ego are bigger than the entire universe. Understand? Carl Sagan rightly said, okay, we are a speck of dust in the cosmic race, even in the solar system. Okay, but even though we live in a small speck of dust, we have people whose egos are bigger than the universe. Okay, that's what Carl Sagan exactly said. That's why you never argue, never ever argue at any cost. If you're arguing with me, I will take as a healthy argument, but never argue with your senior examiners. Many people are not at all open to arguments. If they say something, even if like Harrison says something different, tell yes, accept and move on. That's all. They will also get their ego satisfied. If you don't tell yes and you say Harrison says this, then you will say, what their ego is Harrison bigger than me. That's what their ego is. Okay, bloody Harrison has written an entire textbook which is used by that many students. But the problem with doctors is they think bigger than Harrison themselves. I don't know why. That is not the case. That is never the case. Always you should be humble and be down here. That is never harmful at any part of the world, anytime. I would say that. Okay. Then what else you can ask? Maybe vaccination history and drug history. Okay. Vaccinations is not that important with regards to cardiac, but in CNS it becomes very important because of the post-in vaccination GBS and ADAM. Very commonly after vaccination you can encounter Guillain-Barré syndrome and your ADAM, acute disseminated encephalomyelitis also. So that's why in CNS it's important, but cardiac I would feel like not that important. Maybe one association, diphtheria can cause myocarditis. Argument's sake again. Okay. So if you don't take diphtheria vaccine, you can get diphtheria and you can get myocarditis. So argument. Okay. So, but apart from that, it's not that important. And maybe COVID myocarditis. If you take COVID vaccine, you may not get myocarditis. If you have not got COVID vaccination, there is risk of developing COVID myocarditis. What COVID does not cause? We don't know. From head to nail, every problem they have nailed it. Okay, drug history, why? This is very important for cardiologists. Why it is important? Patient might be taking a list of drugs. You need to always look at the drug history. Again, Indian examiner, I mean, I don't know why there is so much of nonsense going on in Indian exams. Say they ask like, patient should say the drugs. How the patient will know the drugs? Unless until you open and see the drug history, whatever they are having previous. That's what they do in their clinic also, bloody. When a patient is coming, are they asking the patient? No, they are asking the old prescription, no? Then they are seeing the old drugs and they are coming to a conclusion there will be a diagnosis over there. But I don't know why they come to an argument here. You should not see the patient's old records and just ask how the patient will know. That's what my question is. What drugs they are taking. If the patient is very, very well educated, then fine, I can understand. He will say, I'm taking Lasix, I'm taking Aldactone. He will say himself. But the patient is not educated, how will he be able to tell? It's not possible, right? So drug history is very important. Two things. One is heart failure drugs, very, very important. It makes a lot of sense because digitalis toxicity, very common. If the patient is on digitalis, or if the patient is on Lasix, it can result in dehydration. Or you can come to a conclusion that the patient is in heart failure, already a heart failure patient. Or the patient is taking any kidney drugs. So it will be very well known. So the drug history. That's why drug history is very important. With related to cardiology, heart failure drugs are very important. Then second, penicillin injections. That's what they will expect. I don't know. This is again a old examiner's typical question. Penicillin injections, because even now many patients with rheumatic heart disease are taking monthly penicillin injections. Again, remember, I will talk about rheumatic fever in detail later on. The oral penicillins are not superior to injection penicillins. Injectable penicillins are considered to be superior. Oral you have to take daily, but that is inferior compared to monthly penicillin injections, which are shown to be having superior benefits. So that is very important. Pointed towards a already existing rheumatic heart disease. So even before going into the examination itself, you know that the patient is having a background RH3 just by asking the history of penicillin injections monthly. That's why these drug history are very, very important. So genetic, marital, diet, vaccination and drug. Again, it's very personalized. I cannot really comment on what your examiner will expect in your hospital. So go accordingly, but at least you can cover up and touch up all these things. Do you understand? So that's why history taking is very important. Sequentially, when you see the history itself, you will be able to say, so what's happening to the patient? So in your patient, any of this is there? I mean, stop texting and you can say, any of this thing is there in your patient? Okay, good. So the patient is having, taking monthly penicillin injections, okay? Okay, monthly for how many years she's been taking? How many years? No idea. It's not mentioned. Checking now. Okay, why that is important? Because according to many guidelines, there is a rule for how many years they have to take. So you need not give inappropriately for a long time. I'll talk about that rheumatic fever. You have WHO recommendations and you have ACCHA recommendations also. Depending on whether the patient is having carditis or valvulitis or no carditis and valvulitis, the duration of penicillin prophylaxis will vary. That's why the duration is very, very important. So whenever you say drug history, always say how long they have been taking these drugs. That will give you an idea about toxicities also. For example, amiodarone toxicities and all will happen generally if they take months together. For example, what is the important side effect in amiodarone toxicity? It can cause any toxicity. Remember, amiodarone is a very, very important drug for your exams. Amiodarone digoxin extremely important. So what is the most important amiodarone toxicity? Okay, it can affect the lung. It can cause pneumonitis and pulmonary fibrosis. It can affect the liver. One of the very few drugs that can cause complete cirrhosis is amiodarone, along with methotrexate. Methotrexate is very important. Okay, amiodarone can cause liver injury and this thing. And they can cause corneal deposits. So they can affect the eye also. And they can cause corneal deposits. One of the earlier sign of amiodarone toxicity is corneal deposits. It can happen as early as 3 months. And almost 100% incidence in any amiodarone toxicity, corneal deposits. Very, very early sign. Then what else they can develop? Thyroid, correct. Okay, thyroid issue. Okay, I mean, for your information, that's trachea. I'm drawing the thyroid over the trachea. I'm very poor in diagrams. Okay, sorry for that. Okay, that's thyroid. So it can cause both hypothyroidism as well as hyperthyroidism. I don't think examiners will ask you, but maybe you can ask about two important types of thyroid disease there. One is called AAT type 1, amyotrophic thyrotoxicosis type 1, and amyotrophic thyrotoxicosis type 2. Two types are there. Okay. Type 1 typically happens in a diseased thyroid gland. Already diseased gland. Type 2 can happen in any gland. Diseased or not diseased doesn't matter. Type 2 can happen in any gland. The reason for type 1 is Jod-Basedow effect. So what is Jod-Basedow effect? Remember, Jod-Basedow effect is in a diseased thyroid gland. In a diseased gland. Already some disease is there in the thyroid gland. Like some thyroid disease going on. Like it could be Graves' disease, something. In a diseased thyroid gland, if you give iodine, there is a possibility, not always, there is a possibility that iodine can be taken up to produce more thyroid hormone. That is called Jod-Basedow effect. So because it's a diseased gland, Jod-Basedow effect is very likely because amiodarone contains 37% iodine by weight. That's why it's called iodine. Okay, amiodarone, isn't it? Contains a lot of iodine. Okay, so that's why there is another drug called drodinerone, which is devoid of thyroid side effects. Why it's called drodinerone? Because it is drained of iodine. That's why it's called what? Drodinerone. It is devoid of what? Thyroid side effects. But remember, amiodarone is the only drug, to be honest, which is extremely safe in cardiac failure patients. That is why a patient is having any structural heart disease or heart failure. The antiarrhythmic that we generally prefer is amiodarone. We don't prefer other antiarrhythmics because they are not proven to be very safe or cardiac friendly. Okay, Jod-Basedow. So what is the reason for AAT type 2? Generally, it is due to thyroiditis. Okay, AAT type 2 is generally due to thyroiditis. Do you understand? Thyroiditis, inflammation and injury to the thyroid gland itself by unknown mechanisms. And hypothyroidism is due to what? This generally happens in a normal gland, on a background of a normal gland, where there will be another effect of iodine called as what? Ulchaikov effect. So generally in acute iodine amiodarone loading, you can expect hypothyroidism. See, two drugs very important for hypothyroidism: lithium and amiodarone. Very, very important. Lithium can prevent the iodine entry. Okay, lithium can prevent the iodine uptake by the thyroid gland. That is why in hyperthyroidism and all, they tend to give lithium previously in older days. And amiodarone also can cause hypothyroidism. But in acute, like bolus of amiodarone can result in hypothyroidism because of massive dose of iodine can result in what? Ulchaikov effect. That's why. So amiodarone, thyroid disease is very important. Second, third, it can affect the skin, man. Can cause skin hyperpigmentation. I'll show you later on. In a general examination, I have a slide which I'm going to show. Everything is coming up in the afternoon because now only we are getting settled to the class. Get set to for the rest of the class. So I'll show you a lot of slides. Okay, skin hyperpigmentation. That will be like bluish gray kind of hyperpigmentation. Very, very common after prolonged intake of amiodarone. Generally, it happens by around 20 months of amiodarone intake. If you take amiodarone for a long time, by approximately 20 months of amiodarone intake, you can get this kind of bluish gray hyperpigmentation in the skin. Nail hyperpigmentation is very rare with amiodarone, but skin hyperpigmentation with prolonged use of amiodarone, it's common. You can think iodine is what color? Blue, isn't it? Logically. So it produces bluish gray hyperpigmentation. Easy to understand. Don't mug it up. And second important is digitalis. Okay, these are the two drugs they will concentrate in the exam. Digitalis. When it comes to side effects of the drugs, I told you digitalis toxicity means first side effect is nausea and vomiting. Okay, so this is the first side effect that you're going to experience. That's why that point I told you in the history is very important. Then apart from that, what else can cause digitalis toxicity? What else can result in this thing? Yeah, correct. Yellow vision. Okay, either it's called xanthochromia or xanthopsia. I'm not sure about the small technical terms, but yellow vision, I can say. It's very rare generally. Third is you can get arrhythmia itself. Digitalis can cause any arrhythmia on paper. They can result in both bradyarrhythmia as well as it can result in tachyarrhythmia. If you talk about bradyarrhythmia, what is the specific bradyarrhythmia for digitalis toxicity? Bigeminy. Okay, I'll talk about bigeminy more in detail when I'm talking about the pulse. So ventricular bigeminy is the classic arrhythmia. It's a bradyarrhythmia actually. So it's digitalis toxicity. Then you can develop any heart blocks. any heart block can happen. The only exception is MOBITS 2. MOBITS 2 alone is not shown to happen in digitalis toxicity. Except MOBITS 2, any other heart block can happen. First degree, second degree, complete heart block, anything can happen. Tachyarrhythmia, what is the characteristic tachyarrhythmia? This is digitalis toxicity. That's called non-paroxysmal atrial tachycardia with block. Non-PAT with block. Non-paroxysmal atrial tachycardia with block. That's a very specific tachyarrhythmia with regards to digitalis toxicity. Then there's another specific tachyarrhythmia that's called bidirectional VT. Bidirectional ventricular tachycardia. Bidirectional VT. Another very specific tachyarrhythmia of a digitalis toxicity. Non-paroxysmal atrial tachycardia with block and bidirectional ventricular tachycardia. Apart from that, it can cause any tachyarrhythmia, but exception is it will not cause atrial fibrillation. That's why it's commonly used in atrial fibrillation. Okay, you understand, isn't it? Majority of the patients who receive digoxin will be on AF. So if it induces AF, how we can use in AF? It doesn't cause AF, but it can cause any other tachyarrhythmia, and it doesn't cause flutter also. It doesn't cause atrial flutter. Okay, so these are the tachyarrhythmias with digitalis. And what augments the side effect of digitalis? What increases the side effect of digitalis? Good, hypokalemia, very, very important. Hypokalemia can worsen the digitalis toxicity. The reason is very simple, because digitalis works on what? Sodium, potassium, ATPase. So if you have a cell like this, ICF, ECF, on the ECF side you have potassium binding site, on the ICF you have sodium binding site. So sodium will be taken in and pushed to the outside, potassium will be bound to the outside and pushed inside. So digitalis, where it binds to the potassium binding site of sodium, potassium, ATPase. If you have lesser potassium, the competition for the potassium binding site will be low. So digitalis can bind more avidly with the potassium binding site of the sodium, potassium, ATPase. So toxicity will increase. So the risk of arrhythmia will increase. So hypokalemia increases the risk of both amiodarone as well as digitalis. Do you understand? It's not just digitalis. Hypokalemia is going to increase the risk of both amiodarone or any class 3 agent for that matters as well as digitalis. That's why it's very important. Okay, generally when you talk about drugs, these are the questions they will ask. Amiodarone toxicity and digitalis toxicity. Very, very important drugs. Other drugs, I cannot be sure, but at least these two, very commonly they will ask. If they ask about Lasix, what you will say? What is the single most important toxicity of Lasix? In an acute heart failure patient especially. Perfect. Ototoxicity. Correct. Ototoxicity. Because the sodium potassium 2 chloride transporter is in the ears also. So, I mean, Lasix in the very small dose, it will not cause problem, but acute doses, large dose of Lasix can result in ototoxicity. What is the reason? The sodium potassium 2 chloride ATPase is present in the ears also. That's why. And remember, you should have a high dose Lasix, then only. That's why it is common in patients with acute decompensated heart failure. During that time only, you are going to infuse what? Too much of Lasix. In a chronic heart failure, don't give that much Lasix. That's why in ADHF patients, risk of ototoxicity is very high. That's also a point. Lasix ototoxicity. Okay, what else is there? Spironolactone. What is the most important side effect? Spironolactone. Few drugs, few cardiac drugs, I'm telling. Hyperkalemia. Very, very important side effect. And let me tell you the important side effects alone. ACE inhibitors, very important heart failure drugs. ARBs, both can result in what? Hyperkalemia, but the risk of cough and angioedema is higher with ACE inhibitors than ARBs. But both can result in hyperkalemia. Then spironolactone, we can put that under MRA. What is MRA? Mineralocorticoid receptor antagonist, which means they are aldosterone receptor antagonists. What are these drugs? Spironolactone and eplerenone. Two drugs are there. Both can cause hyperkalemia. I told you have two drugs. One is called aldactone. Second is, I'm writing the brand name. That is spironolactone, and second is eplerenone, right? In that, spironolactone has more anti-androgenic action, so risk of gynecomastia is very high. It's more anti-androgenic. So gynecomastia risk is quite high with spironolactone. Eplerenone has a lesser anti-androgenic risk because it's more selective for mineralocorticoid receptor than androgen receptor. Spironolactone is little less selective for mineralocorticoid receptor. It can work on the androgen receptor also, resulting in gynecomastia. But both can result in hyperkalemia. And remember, typically any MRAs are contraindicated if serum creatinine is more than 2.5. You cannot give serum creatinine more than 2.5. But ACE inhibitors you can give depending on the situation. Again, I'm not about to tell all these things because it will waste time. But depending on the situation, ACE inhibitors can be given up to creatinine of 9, 10 also. Creatinine is not a contraindication for ACE inhibitors or ARBs. But spironolactone cannot be given if creatinine is more than 2.5. Okay. So what other drug that we commonly use now will cause cough and angioedema? What other drug that we use commonly for heart failure will cause cough and angioedema? Arni. Okay. Sacubitril valsartan combination. Sacubitril is a neprilysin inhibitor. Okay. Sacubitril also has a risk of developing cough and angioedema because what is the mechanism of ACE inhibitor induced cough and angioedema? Bradykinin excess. So the bradykinin clearance is affected if you give ACE inhibitor. Similarly, neprilysin also metabolizes bradykinin. So if you give a neprilysin inhibitor also, bradykinin levels may become high and they can also induce cough and angioedema. So another drug that can result in cough and angioedema is Arni. Because it contains valsartan also, it has a risk of developing hyperkalemia also. So Arni is very similar to what? Giving ACE inhibitor. That's what I'm trying to say. But with the additional natriuretic effect, that's all. Do you understand? But Arni is very similar to like giving a ACE inhibitor only because it produces both cough and angioedema as well as it can result in what? Hyperkalemia, because sacubitril we don't give alone because we give along with what? Valsartan. So the valsartan component can cause hyperkalemia. That's why it's very important. Arni. Then what else? What other drugs we can use? Beta blockers. Beta blockers, again, very important side effects. They are negative inotropic agents, so they can produce bronchial asthma. I mean, they can produce bradycardia, and they can produce heart blocks, and they can worsen reactive airways disease. Reactive airways disease means any disease which has bronchial hyperresponsiveness. Classically bronchial asthma, but even many COPD patients will have bronchial hyperresponsiveness. So any patient who has reactive airways disease, you're not going to, especially severe RAD, severe reactive airways disease, beta blockers are contraindicated. You cannot give. Mild to moderate still you can give, but severe better to avoid. But even some guidelines are telling cardioselective beta blockers you can still give, not a problem. Only non-selective beta blockers should be avoided. And beta blockers, especially non-selective beta blockers, can cause sexual dysfunction also in some patients, and they can cause nightmares, poor sleep, and they can worsen the glucose intolerance. They can worsen the diabetes status. They can worsen the lipid status. So these are all generally with non-selective beta blockers. The currently used selective beta blockers doesn't have these many side effects, but they might expect the sexual dysfunction. Okay, that is a very important question in the main exams by many examiners. Sexual dysfunction with beta blockers, especially non-selective beta blockers. Even some selective is known to produce, but generally with non-selective beta blockers. Okay, these are the important things of beta blockers. What other heart failure drugs that you use? I told you about all the drugs. Ivabradine. Ivabradine is a funny current inhibitor. Two peculiar side effects of ivabradine are there. One is bradycardia, of course, the most common side effect. Second, yes, that's called phosphines. So what do you mean by phosphines? You get this kind of flashes of light, colorful flashes of light. That's called phosphines. That's a visual symptom. How you can remember ivabradine is there, no? I produce visual symptoms. That's called ivabradine. Isn't it? And I'm going to produce bradycardia also. And I am a funny current inhibitor. Okay? IF inhibitor. That is ivabradine. So you can easily remember. What other drug is there? That's all. I think majority of the drugs we have covered. So whatever drugs that has been used in heart failure, I've covered everything. And most of the anti-anginal drugs, I mean aspirin and all, you know. I don't want to say it can worsen bronchial asthma again. Aspirin can cause bleeding, especially GI bleeding. That's a high risk. Apart from other risks, GI bleeding risk is the highest with aspirin. You know, clopidogrel, any bleeding again can result in any bleeding. So other things you can easily say. It's not a big deal. But these drugs, generally, they are going to ask in exam. I mean, these drugs are not just important for your morning exams. It's important for afternoon Viva OC also. Because in afternoon Viva OC, they're going to ask instruments and drugs only. At least one drug they will keep. One of these drugs, they'll give spironolactone tablet and they will ask you. What are the effects and side effects? At least mechanism and 2-3 important side effects. And what is the dose of the drug is very, very important. Okay. Cardiology, typically we use around 25 to 100 milligram dose, spironolactone. So what is the dose of, I mean, ACE inhibitors, they won't ask generally because you have variety of ACE inhibitors. So right from enalapril to perindopril, so many drugs are there. So I don't think they will ask. But commonly what they will ask is spironolactone dose. Both spironolactone and eplerenone dosage is 25 to 100 milligram per day as far as cardiac conditions are concerned. But in liver conditions, in hepatology, liver conditions, you're going to give up to 200 milligrams, 400 milligrams per day. In liver cirrhosis patients, you can go up to what? 400 milligrams per day. But in cardiology, we give only up to 100 milligrams per day. What is the dosage of Lasix? Furosemide. Lasix dosage. You can start at 10 milligram also, and you can go up to what? 160 milligram per day. But remember, generally cardiac and renal patients will require very high doses. They don't require low doses because of the pharmacokinetics of the drug will be altered. And you need very high doses. So 10 to 160 milligram per day is the Lasix dose. What are the side effects of Lasix? I told you ototoxicity, that's very important. This is what the examiner expects. Apart from that, electrolyte imbalances can happen. You can get hypokalemia, you can get hypocalcemia, you can get hypomagnesemia, but hyponatremia is very, very rare. Even though some old examiners expect this point, but with Lasix, generally hyponatremia is very rare. Thiazides, very commonly you encounter hyponatremia, but with Lasix, with loop diuretics, hyponatremia is very, very rare. Because of a lot of reasons, we don't get hyponatremia. Okay. And what is one situation where you don't use Lasix, but the patient is in renal failure and cardiac failure? Huh? Blood donation. Hematuria. High blood urea. No. You can still give Lasix. No, pulmonary edema definitely will give, ma. The most important area where you don't give, where you can have both cardiac and renal failure, but you don't give Lasix is multiple myeloma, cast nephropathy. Because Lasix is shown to increase the cast formation and cast precipitation in the tubules. That's why in multiple myeloma, don't give Lasix. If you suspect a cast nephropathy, history will be obvious. That is the case. That's the one area where should not use Lasix. Definitely. Okay. Then apart from that, dosage is something very important about Lasix. IV Lasix to oral Lasix. Is there any difference? Yes. IV Lasix is 2 times more potent. I mean, 2 times more potent than oral Lasix. 2 times more potent IV Lasix, which means if you are giving 10 milligram of IV Lasix, it's equal to what? Giving 20 milligram of oral Lasix. If you are giving 100 milligram of IV Lasix, it is equal to giving 200 milligram of oral Lasix. But remember, our maximum dose of 160 milligram is based on oral Lasix, not IV Lasix. Okay, I have to be clear. So IV maximum you can give only up to what? 80 milligram. That's the recommended dose. So be very clear. And these are all very, very important. And what about torsemide? There is another drug called torsemide, isn't it? Similar to Lasix. So what is torsemide? Torsemide is 2 times more potent than IV Lasix itself, which means 10 milligram of torsemide is equal to 20 milligram of IV Lasix is equal to 40 milligram of oral Lasix. Do you understand? Okay, so this is the conversion that we generally use. I want to tell one more thing. Okay, and you know one thing, I mean this loop diuretics are contraindicated in patients with sulfa allergy. Very important, because loop diuretics contain sulfa component. I mean, these are the practical points they will ask you, man. If a patient comes to you with sulfa allergy, what diuretic you should avoid? You should avoid almost all the diuretics. Many diuretics contain sulfa, especially what? Loop diuretics. Which loop diuretic does not contain sulfa? It's not available in India though. Ethacrenic acid, correct. Ethacrenic acid is something that does not contain sulfa. That's the only loop diuretic that does not contain sulfa. Remaining all the loop diuretics are sulfa. So you cannot use loop diuretics except ethacrenic acid in a patient with sulfa allergy. Another important point is very commonly asked is what anti-diabetic drug you will avoid. The name itself is there, sulfonylureas. Isn't it? You don't use. And the irony to the peak is many people will tell self-reported sulfa allergy. As you can see, many patients in the case sheet will have sulfa allergy, but they'll be getting glimepiride for 20 years. That's why you should assess carefully whether really it is sulfa allergy or not. Especially with posh patients I have seen, they will be coming to me and telling that, sir, I have sulfa allergy, don't give anything with sulfa. And we see the old history, they will see 20 years glimepiride they'll be taking. Or glibenclamide they'll be taking. and they'll complain that I have self-allergy, and they'll self-proclaim that they have self-allergy. That's why you need to assess whether it's a true self-allergy or really it is, because this kind of self-allergy concept and all is created by very old people in the past. So whenever they get some allergic reaction, they say you have self-allergy. So this is very common in the past, and that is continuing now also. We as a youngster, we need to avoid all this bias. And again, penicillin allergy and all, you should not take very significantly, because penicillins are life-saving drugs, beta-lactams. And just because patient complains with penicillin allergy, I'm not going to stop using beta-lactam drugs. So if the patient tells penicillin allergy, what are the 4 beta-lactams? You have penicillin, you have cephalosporin, you have monobactam, that is only one monobactam is available, that is aztreonam, and number 4 is what? Carbapenems. Okay, you have 4 basic beta-lactam drugs. All these contain beta-lactam ring. Suppose if the patient is taking penicillin allergy, what is the risk of getting allergy to cephalosporin? I mean, cross allergy to cephalosporin. If it's a true penicillin allergy, still, what is the risk of getting cross allergy? Less than 2%. What is the risk of getting cross allergy to carbapenems? Less than 1%. What is the risk of getting cross allergy to monobactams? 0%. That is why your guidelines say whenever you have allergy to penicillin, prefer aztreonam. Have you ever heard of that? You go and see the community-acquired pneumonia guidelines. In that they would have given, if the patient is having penicillin allergy, and if you want to use a beta-lactam, use aztreonam as an empirical option. Because that has, legally speaking, 0 risk of cross allergy. But technically speaking, you can use any of the drugs. Doesn't mean you should not use cephalosporin. I use left and right. Even if the patient has penicillin allergy, I will use left and right. What I will argue to the patient is, you don't want penicillin, right? I'm giving cephalosporin only, which is a different class altogether. They will ask, man, many patients who are some big shots, and they'll ask, sir, you are not giving any penicillin? No, I have penicillin allergy. I'll say, no, it's cephalosporin only. Or I'll change to carbapenem later on. Patient, okay, sir, you give whatever you want. Okay, fine. That's all. So these are some of the important components that you need to know. Dosing also is very important. Spinal lectin, epinephrine, Lasix and spinal lectin, very commonly they will ask, what is the dosing? Okay. Then your past medical history is done and dusted. Okay, what else you have in store? Anything else? Huh? Oh, you are moving to general examination now. You don't want to summarize your history. Summary of your history. That's very important, no? You have to tell a summary. After history, that's very, very mandatory. So what is the reason for summary? Because you are told so many nonsense, honestly speaking. Yes or no? So as an examiner and as a student also, you got confused. So what's really happening to the patient here? That's what I'm asking. That's summary. So tell only the positive symptoms. In a posh way, I'm telling at the end, I don't understand your nonsense. Tell me what's happening. That's the exact idea of telling a summary, even though we tell it in a decent way. So summarize all the positive findings. What are the positive findings? And you tell them from the name you can start. Mr. Ruben, 51-year-old gentleman, has been admitted with no complaints, has been admitted with shortness of breath. That's all. Admitted shortness of breath for the last 2 months, which was recently worsening, and EC fatigability. Now you have to tell here. And EC fatigability. These are the 2 positive symptoms you said. Okay, so that's all. Okay. Then what else? That's all. No other negative complaints. And one history you told, no, patient has been taking injections. That's very, very significant for a cardiac case. So patient has been taking some regular injections for the last so many years. Based on these 3 things, like you have 2 cardinal symptoms of cardiovascular disease. Okay, one major, one minor. And you have one important injection history. So based on this, my primary concern is the disorder of cardiovascular system, and I would like to examine the same as my first priority. That's all. So idea is, why you want CVS to be examined first? So why can't you examine neurology first? Why can't you examine abdomen first? So you are trying to say, like, my primary concern is cardiovascular issue. So I'm trying to examine cardiovascular system first and then trying to move on to the other systems. So this is how you have to summary. Don't say any nonsense here. No syncope, no pedal edema, that all is not required at all. Just say what is there in the patient, what is positive, and that you should substantiate as a reason for examining the CVS first as the primary concern. That's all. Even in neurology, the same thing applies. This is how you summarize the history. So once you summarize, then you will move on to what? General examination. Okay, general examination we'll discuss after the lunch break, obviously, because you look very concerned about your lunch. Maybe I think after 2:30 to 45, it becomes increasingly difficult to get the lunch, of course. But let me show you some important breathing patterns only before going into the, because the problem with this thing is everything goes to the iCloud. So every time I have to download. Okay, I'm showing. Okay, you can see what this kind of breathing is. I don't know whether you're able to observe or not. So now apnea, right? Now, again, he went for apnea. Now the breathing starts. Some breathing is going on. There is no particular pattern here, isn't it? So what is this breathing? This is Biot's breathing, basically. So if you want, you can see one more time. You can see now breathing. Depth is varying. And again apnea, breathing. Stopped again. Then breathing again. So this is typical Biot's breathing. Neurological issue. As you can see, the child has been intubated. It's a neurological problem. So this is another characteristic breathing. What is this? What's happening here? It's deep breathing or shallow breathing? Okay, somebody wants to tell shallow? No. So it's a deep breathing, right? Definitely it's a deep breathing. And the respiratory rate is also increased. What is this? Rapid and deep breathing. Labored. Very labored breathing, right? She's struggling. This Kusmals. Where will you see this kind of breathing? Pardon? Yes. And as you can see here, in this limb, I'm not very sure, but in this limb, she had an AV fistula, which means she's a renal failure patient, and that precipitated severe acidosis. Because one of the important reasons for severe acidosis is renal failure also. That's the reason why he had this issue. Cheyne-Stokes, I'm not able to get it because it's not getting downloaded. Yeah, got it. I'll show you in a while. You can see the pattern here. Observe for the crescendo decrescendo pattern. It's coming, it's coming. Yeah. Observe the crescendo decrescendo pattern here. When you see the breathing here, apneic. Slowly he will start breathing and his depth will slowly increase. You can see the movement of the shirt. You're not able to see anything. I think he's breathing, at least you can see, no? Yeah, it's actually increasing in depth over time. Now he's breathing more and more, and slowly it will become shallow. See, it's becoming shallow now. Now it's stopped. You can see that crescendo, decrescendo, but it's very subtle. That's how medicine is all about. You have to pick up all those things. This is typical Cheyne-Stokes respiration. Crescendo, decrescendo pattern. I'll give you one homework. So you have to find what is this breathing. What is this breathing? This is called as paradoxical breathing. What is happening here is during inspiration, his abdomen is going down, and during expiration, his abdomen is coming up. Normally, it should not happen, isn't it? Normally, it happens otherwise. Normally, your inspiration should cause your abdomen to come up, and your expiration should cause your abdomen to retract inwards. But here, something opposite is happening. That is what we refer to as paradoxical breathing. So you're going to find out where you are going to see paradoxical breathing. That's the homework for your lunch. You can go for lunch now. Bye.